Okay, hey, we're back. Module 4, Lesson 2. So, in this lesson, we're going to talk about prescription therapies for perimenopausal and menopausal symptoms or to lower risks of menopause. So, we'll talk about that. And then in the next module, we'll talk about hormone therapy. And we'll get there. So, we'll get there. Okay, well, again, disclaimer, disclosure. Remember, this is for informational and educational purposes. This is not medical advice. Please learn what you can and communicate with your own provider about what you've learned or what you are deciding that you want for yourself. Okay. Again, I'm not getting paid by any drug company or a specific drug or a lab or imaging company. So I'm just giving you the advice based on my knowledge, my years of experience, the latest studies, and and kind of what common sense makes common sense. Okay. So let's first talk just about contraceptives in perimenopause, because even though we're going to talk about hormone therapy, and sometimes we'll use a low dose birth control pill or other contraceptives as part of hormone therapy, I wanted to just throw it out there as a separate in this non-hormone therapy category because some women need birth control. Okay, just because you're starting to have hot flashes and night sweats, remember we talked about the symptoms could last for many years, and so it doesn't mean you're not fertile. It doesn't mean that you might not get pregnant. You might, you're still ovulating, maybe not as regularly. So you do need birth control. And going on a low dose birth control pill can help with a lot of the symptoms, prevent a lot of the symptoms, and it can also maintain your bone health. It can help lower colon cancer risk. Again, we talked about a little bit lowering ovarian cancer risk by thinning the lining inside the uterus. It lowers uterine cancer risk. So there's a lot of benefits to taking a low dose birth control pill, and it does not increase your risk for breast cancer. So if you are still needing birth control or you realize you're years away from actually getting to menopause, you don't need to go on hormone therapy that's menopausal dosing or closer to menopause. This is something you could do. You could take a low dose birth control pill. I've done this for a lot of patients, and then I have said to some patients that let's just keep you on this until you're 51 to 52, and then transition you over to hormone therapy, like hormone replacement therapy for menopause. So that's perfectly fine to do it that way. There's not one right way of doing things. The So yeah, and the pill I usually will choose if a woman tolerates this pill. And every pill, there's a few different pills I like. My favorite is called low estrogen because it has the lowest amount of estrogen. It was originally being developed as a hormone replacement therapy for menopause, and then when doing the studies with it, they discovered that it also was suppressing ovulation. So they just made it into a birth control pill. There's no generic of it, but has pretty good insurance coverage. So low estrogen is my favorite. Again, not getting paid by the company that makes it. And another pill that I like, that especially if you're having weird bleeding, also brand only because it has a unique type of estrogen in it and progesterone called Natassia. I've used it specifically for patients who have kind of unusual bleeding. And it's very well tolerated. And then a lot of women who are experiencing various perimenopausal symptoms seem to do well on something called Aless, which is also low dose, or Yasmin, which is Yaz, which is low dose. Okay, so those are my picks for low dose birth control pills if you were thinking of taking one of those. You should not be taking a birth control pill that has more than 20 micrograms of estrogen in it. It's just not, there's no need for it. The higher dose ones are not more effective unless you're in an unusual situation where you were having a lot of bleeding issues or something. But otherwise, 20 micrograms at the most, and 10 micrograms is my preference for a low dose birth control pill. Okay. Obviously, some women can't take birth control pills, and you should discuss that with your provider. Now, we talked a little bit about this in another module, but the selective serotonin reuptake inhibitors, or SSRIs, which are usually medications used to treat anxiety and depression, but these medications can actually treat hot flashes and night sweats. Paxil, they actually came out with a branded version of Paxil, and I'm blanking on the name. And so they branded it and they made it in a 10 milligram dose. Um, and it's just you could get the generic and just make sure you're only taking 10 milligrams. The lowest dose is 10 milligrams. So Paxil, oh, actually, no, the branded was 7.5 milligrams, just to make it so that you couldn't take a generic. But taking generic 10 milligrams a day would do the same, be just as effective. And Zoloft similarly has been studied. You can take the generic, and it decreases the frequency of hot flashes and night sweats. And it's treating anxiety or mood symptoms that you might be having. Now, these medications are not for everyone. There are potential side effects you can experience from these medications, like some women get worsening of their mood symptoms and also or worsening of insomnia. Everyone reacts a little differently. Some women get headaches when they take these medications. So obviously you're going to consult with your provider. If you are thinking, I don't want to go on a hormone and I really the mood symptoms are driving me nuts and I want to take something for hot flashes and night sweats, this is certainly an option because you're treating two things at one time, the mood symptoms as well as hot flashes and night sweats. The next group of medications I wanted to talk about are the selective estrogen receptor modulators. All right, now these are just like the name, right? They selectively bind to estrogen receptors in certain parts of the body. So the first one, raloxifene, which the brand is Evista, that one binds specifically in the bones. So raloxifene actually helps improve bone density, and it's really more of instead of estrogen, and if you didn't want to take Fosamax or one of those biphosphonates, which are the treatments for low bone density or osteopenia or osteoporosis. So if you didn't want to take one of those medications, this could be an alternative because it does improve bone density and reduces vertebral fracture risk. The data is not great on it improving or reducing hip fracture risk. So it really would be something you would take earlier on before you developed osteopenia, osteoporosis in your hips. The other thing about raloxifene is that it actually reduces the chances of invasive breast cancer. So if someone has a higher rate of a family or a strong family history of breast cancer, and they're adamant about, they need to do risk lowering, but they don't quite qualify for taking something as strong as the medications like tamoxifen, or which is used for breast cancer treatment. If they took raloxifene, it will have a dual effect. It will improve bone density and lower risk for invasive breast cancer. The other one here on this slide, ospemifene, or Osphena is the brand name. And this is a medication that is only for genitourinary syndrome of menopause. Okay, it is specifically there to to attach at the estrogen receptors in the vagina and vulva to improve the estrogenization of that tissue. So it's as if you are applying estrogen to that area, and you don't have to use an estrogen. You're just you're taking a pill every day, and sometimes the first month or so you could have some hot flashes as a result of taking it. So there's a few side effects you have to know about before you start, and just to be aware that they usually go away. And so basically it's just a pill you take by mouth, but it treats the vulvovaginal symptoms of menopause and improves the lubrication and the stretchiness of the tissue. And because it does that, it can because it's improving the stretchiness of the tissue, it lowers that urgency frequency that may be related to vulvovaginal atrophy. I haven't prescribed that medication in a number of years. Maybe the first year it came out, I was prescribing it more, but more and more data has come out that vaginal estrogen is really, 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 really safe. So I don't know how much this medication is getting prescribed anymore. Okay, now these two medications are the new kids on the block. Okay, Veoza came out, I guess maybe like 2 years ago, and Linquit. I think I'm pronouncing it correctly. Linquit, maybe. It just came out or was FDA approved in October, and I'm recording this right now in December of 2025. So it's very new. Um, what these two do, and I don't know if you remember, I mentioned way back some neurokinin receptors when talking about thermoregulation and the hypothalamus, where the thermoregulatory center is. So these neurokinins are acting in the brain and the thermoregulatory center. And so, what Veoza does is it antagonizes that receptor so that the neurokinin 3 is now in higher doses, isn't acting in that thermoregulatory center. And so, therefore, there's stabilization of temperature. So, Veoza and this other one, Linquit, basically cross the blood-brain barrier, act in the thermoregulatory center of the brain on these receptors, the neurokinin 3 and neurokinin 1 receptors, and they reduce the frequency and severity of vasomotor symptoms. And reportedly, there are very few side effects, but one of the main thing to be concerned about is there's a potential for liver function abnormalities. So you have to get your liver function test drawn before you start the medication and have it followed up to make sure that the medication isn't causing any liver abnormalities. But otherwise, it seems to be very effective. I think that the numbers are somewhere in the 60 to 70% reduction in hot flashes and night sweats, which I think is really good for a medication that isn't a hormone if you didn't want to take hormones. The medications, however, are brand only. They probably will be brand only for a long time. So they may be pricey or a higher copay, depending if you pay a copay or if you pay a percent, maybe a higher amount. The companies do have coupons out there that you can download from their websites. So you can get a coupon to use for your prescription, take it to the pharmacy when you get your prescription. And so this just is another nice to have options in this world, right? Okay. And so then here I just want to talk about statins a little bit because statins are medications to help prevent cardiovascular disease. And it might be that you want or need to take a statin in addition to taking something else for symptoms. So statins are intended to treat elevated cholesterol, or maybe not the total cholesterol. Maybe the LDL is elevated or the triglycerides are elevated. So that's what they're targeting. They're there to decrease your cholesterol. And that is going to decrease your chances of getting hardening inside the arteries, developing plaque, and then cardiovascular disease that can cause heart attacks and strokes. So statins can be taken at low doses if you don't have significant lipid panel abnormalities, and they do have potential for some side effects. The most common thing being leg cramping or muscle cramping, and a lot of times you just drink more water or back off on the dose a little bit for a while and then restart. So there's ways to deal with that, and sometimes you'll switch to a different statin and you won't have the side effect. So especially if you do get started on a statin, if you have a side effect, don't give up on it. Just make sure you talk to your provider, because usually you can just adjust the dose and or change to a different one, because there's about 10 different statin drugs on the market right now. And some of them are more expensive than others, but you should be able to find one to treat your elevated cholesterol if you have elevated cholesterol. And I also recommend not, dreaming of, oh, I'm going to be so good with my diet and my exercise and losing weight, and then I'll get my cholesterol rechecked, because so many times I see patients a year later, another year later, and the weight is still there, or they're still not able to exercise because their life is stressful and they're so busy, and their cholesterol is still elevated. So those are wasted years where you're building up plaque. So just if your doctor says something or if it's elevated, just say, you know what, let me go on a medication. And you can go on a low dose. But you can still do those other, dietary modification, exercise, weight loss, but take the medication. Um, the other thing, there's some data on dementia risk and keeping your LDL 75 and lower. So if there's a family history of dementia, that might be something to consider taking a statin for that reason. It might not be something that your provider is educated about, so you may need to come in with a little bit more research, uh, you know, showing the evidence on that. By the way, if you have a provider who is not sure about some of the evidence and you're not sure where to steer them, any provider who has an NPI number, which is like a National Practitioner Identification, where we register with the federal government, any provider with an NPI number can go to, there's a special like AI thing called Open Evidence. I'm not getting any money for promoting this, but they have to sign up with their NPI number and they can look up any medical condition. Like I could look up statins and dementia risk, and I could pull up all these studies and it gives me all the evidence abbreviated, just like you're doing a chat GPT, but you want to have the references, you want to have the articles, and you want to know that they're legitimate articles. And so OpenAI is a way to do that. And your provider can share that with you as well. So there are resources out there, and that type of resource would make it easier. Uh, be careful with using AI like ChatGPT or Gemini for medical questions or for specific articles, because sometimes the articles they may provide are not real. There have been cases like that. So just be cautious there. Okay, so we did talk about the non-hormonal prescription therapies here, except oral contraceptive pills are hormones, of course. And then each therapy targets specific risks or symptoms. And these are, important alternatives for women who cannot or choose not to use hormone therapy. And we mean menopausal hormone therapy. Okay, I'll see you for the next one.